And I can usually acquire some of those directly from schools. But I do have a lot of information to share, comparatively speaking, about that. So the nugget, no, so I recorded last evening uh, the other glandular aspects. So I just finished up thyroid and parathyroid. Spent a fair amount of time on the adrenal cortex, and then the other stuff that was there. Some of the other, the other relevant that become more specific when we get to them. A lot of them will be in reproductive physiology. So that was sent to you, via the, one of those YouTube conversions, and you should be. So give that a listen. Parathyroid, we actually did in bone. Thyroid basically impacts everything, and the whole idea of goiters and hyper and hypo conditions for thyroid and parathyroid. The adrenal cortex one is interesting. That's a very unique system, and when you do get to read it, you're going to understand that the late President Kennedy had a syndrome. I think it was Addison's disease, which involved glucocorticoids, and he was a mess. He was, I mean, it was really the interesting thing. He always looked like a tan, very healthy, slender. He was on a ton of medication. He would not have, he would have been fortunate, I would suspect, had he not been assassinated, to survive a likely second term. And surely he would have gotten a second term. There's even a question. Very interesting, and nobody knew it. He's a very odd and troubled individual in a lot of ways. But as I was saying to one of my other classes today, why am I looking at that? As I was saying in one of my other classes today, that it's for folks my age, baby boomers, who were born 45 since 1960. The Kennedy assassination was an incredibly significant moment. The Challenger disaster years later, landing on the moon 8 years later. Those are places where everybody knows what they were and what they were doing. And a lot of times that's your contact. I always said, if I was there, anybody I would marry would probably have to be in that same generation. And that was absolutely true. So the gland that I did not do, not the adrenal glands, not the cortex, not the medulla. So you got those all put out there for you. Decent sized presentation. There's the Addison's disease that I was telling you about before, and different syndromes that are associated with it. And it's getting there. Not pineal, but that guy. Pancreas is really emblematic of one gland in a similar location being really demonstrating a lot about homeostasis. And irregularities in homeostasis are unfortunately very common. The most common diagnosis in a hospital for people with different kinds of long-term, what we would call chronic illnesses, and oftentimes acute illnesses, and particularly increasing upon aging. And then and that's why I was trying to load one of those PowerPoints had slides about ethnicities and things like that. Is one word: diabetes. So when we say diabetes, we're not talking about salt diabetes. We're talking about sugar diabetes. And here's this gland, the pancreas, which is a double-duty gland, like the ovaries and testes, in the sense that it has exocrine function, when we get to the digestive juices, so to speak, digestive secretions directly into the gut, and it has endocrine secretions released directly into the bloodstream that do exactly the opposite thing. So why would you have two in such close proximity, oppositely triggered, triggering opposite effects, yet work oftentimes in concert? It's almost that idea that you have to be pushing and pulling on a system to keep it almost in balance continuously. And those are known as the islets of Langerhans, is the original name, and they're called alpha and beta cells. Insulin comes famously from beta cells in the islets, and glucagon from alpha cells. And you can see opposed, diametrically opposed, hypoglycemic and hyperglycemic. One releases sugar, one takes sugar out of the bloodstream by facilitating its absorption into cells for energy and for metabolism. So no interest at all to me are, where they're located whatsoever. And, you can always tell exocrine glands because they tend to have a little hollow lumen and those circular kind of, yeah, those circular kind of nuclei, because typically they're simple cuboidal cells. But let's take a look at them individually. Glucagon, okay, extraordinarily rapid elevation of blood sugar. So very potent hyperglycemic. And when blood levels go low, it's triggered. Rising amino acid levels triggers it, and particularly the sympathetic nervous system, because that's where the sugar that we need for fight or flight comes from. It comes typically from the liver with glycogenolysis, and then other sources of gluconeogenesis directly into the bloodstream. But the liver is the principal target, and it's very, very powerful. And so, indeed, you could see, do irregularities in glucagon some contribute to diabetes? They do, because as you will see, it's a balance that's achieved. Insulin, typically secreted when blood levels of glucose increase. So glucagon, in contrast, is typically when blood glucose levels are low. Okay, the opposite effect is synthesized, and again, insulin typically is a more complicated molecule, has to be broken down. So it's proinsulin, or a precursor. Once it's activated, we're not going into the mechanism. It does a myriad of things, principally bringing glucose into fat and muscle cells, slowing down glycogen, being the breakdown of glycogen to glucose, which occur in the liver, and again, inhibits gluconeogenesis also in the liver. So the effects are nearly exactly opposite. We also know that insulin triggers metabolic activity, and again, in the contrast to growth hormone, utilizes carbohydrates as its principal source, where growth hormone and testosterone do the same thing. The androgens do the same thing, except they utilize fats as the source. And we spent a bit of time on that. So it's not needed for these areas. Okay. So does it play a particular role with regard to nerve development, learning, and memory? It does. I don't know if it's clearly understood. Depending on where you go career-wise, at graduate levels or medical school levels, professional school levels, you might explore in detail the well-understood tyrosine kinase mechanism. That's the trigger. Once that's activated by insulin, that's where it has all the different effects, not just metabolic, but mitotic effects and other effects. And it triggers the release of things that basically slow down the activity of growth hormones, you'll see here in the presentation. So we look at these different things. Hey, question?
So I heard fat cells like insulin, um, like, like makes it harder for insulin.
Pardon me?
Like fat cells excessively.
Yeah, I mean, and that's kind of the stuff that I'm going to show you in this article. The article is above my page, okay, but the article gives you some ideas on a molecular level, some of those aspects. I was focusing mostly on blood vessel disease, but a lot of that fat cells do impact that.
Is it because all the glucose goes into the fat cells instead of like muscle cells?
I don't know that. I short answer, I don't know. I mean, I know there's some impact with it. Diabetes is such, for years, when we talk about it, diabetes is not a disease per se as much as it's a syndrome. The definition of a syndrome is it's a series of observable events that are measurable and observable that characterize a certain disorder. So it's not just one thing. We know what certain things are. A heart attack, we know heart cells have died because of lack of oxygen or stroke. But diabetes presents differently in different people, different types that are there. And to me, it's just perhaps the most complex of all the disorders in that regard. So insulin, as we already know, basically once the glucose gets in, it basically facilitates its oxidation and doing the conversion to ATP. Okay, it will, in sufficient quantities, turn into glycogen. That it does mostly in liver and skeletal muscle. And it will, and again, when there's an excessive amount, that's when it begins to change itself into fat for storage vehicles. And again, because we have such limited storage for carbohydrates other than fat. What are the things that resist insulin? High levels, pretty obvious. Amino acids and fatty acids that are there. So again, those are things that tend to work against insulin a little bit. And when we do other activities or other disease states, acetylcholine tends to slow it down. Glucagon directly slows it down, but also epinephrine, like fight or flight, growth hormone, high levels of thyroid, glucocorticoids. There's a lot of things that are involved with that. Okay. And growth hormone, and again, the sympathetic nervous system, they're basically using a pathway. The way I view it is sort of that insulin's there for what we do most of the time. We want to use insulin as our energy source when we're more or less at rest. Okay? Because it favors carbohydrates. We're not in a fight or flight type of situation. We have adequate supply digestively and kidney wise and circulatory to all sorts of areas. It's designed for the vast majority of our time. Most of us, we're like that. We do intense activity or even moderate to intense activity in comparatively short bursts. Or like me, minimal. Look, I walked.
I know.
I walked. Wait a minute.
You do walk. I know.
I know what the heck. Hey, wait a minute.
Right.
Since I always carry my phone with me.
Are you going to tell me your steps?
Yeah, I got a step counter.
All right, go ahead.
So thankfully, now I've already done 2,000 steps today.
There you go.
4,000 yesterday. Okay, Mondays when I'm busy over 4,000. Okay,
You're killing it.
so I mean I'm not killing it.
Well, it's not killing you.
Think how clever. So, but yeah, for a while my wife was doing 10 to 15,000 steps a day. She was really stepping it. Okay, so here, the abnormalities in sugar metabolism. So it's a syndrome. Diabetes mellitus, which is for now, we'll just say diabetes, is basically a syndrome of different types of conditions associated with inappropriate usage of glucose. We are much more able today to diagnose it than we were years ago. We have much more advances in treating it, some of which are not necessarily great. If you want to get in, I haven't really studied it, the whole Ozempic thing and how it's facilitating weight loss. And that's what happens. They get a drug that has a desirable side effect. And the one thing that's been around since forever when it comes to pharmacology is a magic pill that will make us lose weight where we don't really work at it. It's not like good old diet and exercise and balance. Hey, give me this magic pill and I'll lose weight. Most of the time there's a problem. So, and effectively, this syndrome of inappropriate usage is characterized, and now we call it two types. It used to be called adult onset and juvenile onset. We don't call it that. Okay. And then we had insulin dependent and non-insulin dependent. We don't call it that either because there's so many variations. So effectively, type 1 and type 2 really point to in the modern day either some reason that insulin is either not being made or not being made or released, not being made or released or not being made or released sufficiently. So it is a lack of insulin for the most part. Where type 2 is much more about a lack of its activity, and the fault is not the availability of the insulin, but either how it's received or the quality of the receptors. So it's something. So type 1 on the insulin end, more commonly associated with younger than older, and the opposite is true for type 2, but there's no longer a broad brush. And the reality is there's more type 2 than you think type 1. But unfortunately, a lot of type 2s end up having to go on insulin because their system has just gone tremendously faulty. Instability and the characterization. What does diabetes mean? I've said it to you several times. The great thirst. That's the translation, whatever the word root is, whether it's Latin or Greek, and I don't know. Okay, the three polys. Polyuria, because effectively the glucose is an osmotic diuretic. Extra glucose in the urine and the filtrate pulls water along, and we excrete it along with the glucose. Poly, because we are excreting extra water, we're thirsty, polydipsia. And because the cells can't utilize glucose, the cells don't know any better. Effectively, that lack of energy is reflected by an absence of glucose in the cells to be metabolized. And the signal that our brain gets is we're hungry, so we eat. Yet without any effect. And the other effect that they don't include there, which I have for the 25 years I've been teaching, is fatigue. You don't make enough energy, you're tired, or you tire easily. I mean, you're just not making enough ATP. Let's be clear. So the pecking order, metabolically, carbs of any source, fats, proteins. If you're getting down to nucleotides, you're in big trouble. Then you're gobbling up cells in its entirety. But so those are the wary things. Yes, that's the formation of the ketogenic diet from a standpoint of trying to induce not so much diabetes, but a stage where your body intentionally goes toward fats. And as long as you're able to get rid of the fats and excrete them properly, it's not, and that's been around for a long time too. We've been dealing with ketogenic type diets from the original Cambridge diet, better part of 50 years ago, which I was on. And with Atkins and South Beach, and now we have magically we call it ketogenic. Okay. So, and the difficulty with the typical diabetic who is not watching their carbs and is not doing this by intention, is that the next stop is fats. And the trouble is most of the fats that they ingest and most of the fats inside have a great tendency to form back to that beta oxidation, as you're all too familiar with from cell molecular. We chop fats up into carbon units. They bang into each other and form ketone bodies. And ketone bodies become the foundation for, quote unquote, the low density lipoproteins, that, quote, bad cholesterol. And people talk about. And the nature of the ketone bodies and keto acid, that's immediately life-threatening if it gets severe. Ketonuria, again, in the ketogenic diet, that's desirable. We actually do, you can urine test for ketones. Routinely, we test for ketones in the urine as a way to evaluate diabetics if they're under control appropriately, because we shouldn't see it. But for somebody who's doing it intentionally, it's a different idea, and you can blood test for them, because if they're in your bloodstream, then they're going to be in the urine, etc. So, untreated ketoacidosis. How? Because the next big chapter we do after blood vessels is respiratory. From a physiological standpoint, I don't think we'll get to that anywhere near the break. That's post-break once we finish immune physiologically, though we might do it in lab a little bit earlier. And basically, metabolic acidosis. Our metabolism is making keto acids. What do we do to get rid of it? We hyperventilate. Something we see a lot in diabetics out of the control. It's got a fancy name. It's called Kussmaul breathing. They're pushing out large amount, and their breath is very acetone breath. A lot of diabetics get confused because they're unsteady because of secondary problems like diabetic peripheral neuropathy. And what happens then, they walk unsteadily. And I talked about that a little bit in the brain aspect of things. And so they get stopped. Oh, public drunkenness. And let me smell your breath. It's like, oh my God. I can't even tell you how many patients I had that were erroneously brought in until somebody, made a call and somebody got in and said, hey, look, this guy's a diabetic. He's in throes of ketoacidosis. Okay, we're sorry. So hyperpnea, rapid breathing, and then all the other stuff that goes along with acidosis. Heart activity, depressed nervous system, coma, and death. The only good news about this, if there is such a thing as good news, this takes a while. It is not immediately life-threatening. Know this, that in an emergency room situation for you, and I don't know whether they do it any differently now. This is what we did back before 2000, for the advent of a lot of more sophisticated technology. If someone came in with a very high, if someone came in and all we knew about them, there was a diabetic and they were comatose, the treatment is sugar. Okay, you gave them D50, 50% dextrose injection. Because low blood sugar is something that will kill them right now. High blood sugar, we can always get down with insulin. We can titrate out insulin. If their blood sugar is 700 and we take it to 1,000, we just have to put more insulin. So we didn't have a reliable, rapid way of assessing blood sugars like we do now. You had to send it to the lab. It took a certain amount of time. If someone was a diabetic, they didn't have that time. So perhaps they don't do that. And most diabetics carry something in their pocket or their purse, their wallet, their briefcase to administer sugar. And they'll typically slip them under their tongues when they spit. It can come up like that. And that's one of the problems. The classic example is, and I had patients do this all the time who are brittle diabetics. I'm in a hurry to work. I took my insulin. I'll grab breakfast when I get to work. They wake up in the hospital because the emergency room gave them a shot of sugar. And it's like, where am I? Because they took right back to normal. Oh, we found you. This happened to one of my patients. He got to work in a parking lot in Titusville, PA, might I add. He worked at the Senior Citizen Center there. And the next thing he woke up at Titusville Hospital going, where am I? Well, they found you right next to your car. Thankfully, it didn't have when he's driving. These are absolutely true stories. Absolutely true stories. Nothing I know a lot about diabetes. So that's the first nugget. When you have high sugar, it slows down the systems slowly. When you have low sugar, it's almost immediate. And a lot of people will be, there's other conditions. I would get it. There's a condition people like me who've had significant abdominal surgeries. And if they eat a high sugar meal, like for me, it would happen if I'm a candy addict. I can't do it now. I've been sober for the last month. No extra carbs, no visits to Dr. Badger's hoard of candy. I'm Lou. I'm a candleholic. I Lou. I've been sober for four weeks. Good Lou. I should be able. I'm in a lot of those anonymouses. And what will happen is you binge, and the next thing you know, you're feeling shaky. And the treatment, interestingly, is to ingest more sugar, because what happens, you get an overpouring of, like a rebound outpouring of insulin, and it precipitously lowers your sugar, and then you're in trouble. So you can get what's called reactive hypoglycemia. That's also something we see in pre-diabetics. There. I'm going to show you the curve in a little bit. I have a lot of stuff to share with you. I'm sure doing this extemporaneously. This is just flight of my ideas of what I want to share with you about this. So we can have the opposite. If there's a tumor or something, insulin secretion, hypoglycemia, and then it starts with the disorientation. This is rapid, very rapid. So look more of it. So you can take a look at all the different things that insulin does and go through the chart and all the different things it can lose, and we're not going to do it. So I'm not going to go through the BioFlix thing at all about that, but I do want to spend a little extra time talking about it. And I did. So there isn't a lot in that PowerPoint, which because obviously it's not a course about this, but I think I looked at it up on the slide share stuff. The trouble is, I try to download it, I have to set up an account and pay them $11. If I don't cancel it, they're going to charge my credit card.
When I worked at the zoo, there was this kid like passed out all of a sudden. He was like standing up and he just like
Boom, down.
passed out. Yeah. It's because he was hypoglycemic.
It's classic. The guy I was telling about was my patient. People who have had abdominal surgery, a lot of times, like I love maple syrup. I love going out for pancakes. Can't again, month without it. If I have that, I'm going down. My first wife had it because she had the same thing I had. We both have abdominal surgeries, ulcer surgeries.
Dr. Z, do you know Dr. Z? She's like in the nursing department.
No, I don't.
She was also volunteering at the zoo, and she said if the person's cold and clammy, they with candy. And I
Good idea.
that.
Good idea. If you can get it in their mouth.
Yeah.
Okay, so diabetes, characterized by typically hyperglycemia. And now understand, we used to not understand why this was here. Now it is acknowledged that this is an autoimmune phenomenon. The background was that in the kidney, people with diabetes, high blood pressure, and kidney problems were common, long-term diabetics. They found deposits of autoimmune material, which they didn't even know, in the kidney. It was called Kimmel-Style-Wilson disease, or KW disease. And that was a classic combination. We now know those are lumps of agglutinated autoimmune chemicals. Very similar to what we're going to do in lab when we start doing blood testing, except this is on a much larger basis. And so that's really where type 1, so we really think that now maybe 5, 10, a few more, a few less, depending on ethnicity, background, lifestyles, are in that category. So that's what it does. Things that sort of point that you might have problems, blurry vision, again, those thirsty, tired, frequently urinating, hunger, and typically in type 1s, we do see a fair amount of weight loss that's associated with it. So I'm scrolling through this so here are the typical things that you can see. Other things that are longer term. It's generally, this is not necessary. These might be the first clues. Numbness and tingling. So diabetic peripheral neuropathy in my hands, and these were long-term diabetics. I saw anywhere between 1/3 or 1/2 of the individuals had some aspects of this. And this is devastating. I'm sure I told you before, I can't tell you how many people came in my office with stuff stuck in their foot that they stepped on, a carpet tack. And the only thing that got them in to see me is their trailing blood. I operated on that same patient who collapsed, who was almost insensate, had no sensation, doing bone surgery in the office to remove infected bone without benefit of any anesthesia whatsoever. Any. The immunological problems impact difficulty in healing, gum disease, all of these things are there. So you have type 1, insulin dependent, type 2, non-insulin dependent, classically now. And again, we don't use maturity or juvenile like we used to. And then gestational, there are certain clues. My son-in-law, my stepson-in-law, when the baby was born, it was born in November, he texted us, oh, we're born. His baby was 7 pounds, 11 ounces. Okay, he texted 11.7. I'm like, I almost fell out of the chair. You have a big, now, if you have in the old days, before management during pregnancy, a baby over 10 pounds, you were immediately a pre-diabetic or a gestational diabetic. And if you're a gestational diabetic, by definition, you're a pre-diabetic. Okay, now it's 9 pounds because when I was born, the doctors didn't care how much weight you gained during pregnancy. So it's changed. And there's other types. Neonatal, and I'm not familiar with that, with the acronym they're using because I haven't used this PowerPoint. So insulin dependent, autoimmune damage, beta cells, suppression of insulin, called juvenile, but not so much now. Okay, most patients with this type develop prior to age 40. 40 was the cutoff. 15% roughly are in this category. So it's, even though more of them have to take insulin than 15%, it doesn't, the treatment is not it, and they're just showing what it is. Risk factor. These immediately classify you as pre-diabetic. Someone with type 1 diabetes. Nowadays, we can test for diabetes autoantibodies. That immediately is a factor. An increased risk of developing, but not everyone with these develops them. It points to that. Dietary. Increased risk of type 1, low vitamin D. I'm saying vitamin D again, everybody. So it doesn't hurt to take a supplement. You don't have to take a ton. They're easy to find. Exposure, early exposure to cow's milk or cow's milk formula, exposure to cereals before 4 months of age. So they've done studies about that. Things that are there. And a lot. It depends. Culturally, it depends. Typically, we don't have the capacity to break down the lactose that early on. I don't know if that, and a lot of people told me that sheep's milk and goat's milk work more efficiently than that. More common in white races than other races, if that's a politically correct term. I never know what it is. You know me, I try to be politically correct. For Native American giver. In the old days, they call you an Indian giver. Pejorative. Losing the R word for mentally disabled folks. Eskimos, cold Americans. You're no fun. Finland and Sweden, higher rates. Don't ask me. Sir, those are cold Scandinavians. They used to call it maturity onset, now non-insulin dependent. Okay, the beta cells are there, but the insulin is low. That's why you might have to have insulin with it. The vast majority are this type 2. And the biggest single tragedy of all of this is the fact that that was what they used to call metabolic syndrome or syndrome X. That was what we began to see in children and young people who were overweight, inactive, stuck in front of video games, all that type of stuff. That were there. Type 2 is the most common form. Insulin resistance in the body is producing insulin. Insulin sensitivity is reduced, and it's not as effective. Glucose in the blood, cells, etc. Number one, obesity, sedentary lifestyle. So, and unfortunately, we were seeing it in young people who were developing that ketoacidosis, life-threatening, early on. So all of these are part. Muscle cells have more insulin receptors than fat cells. A person can decrease by exercising. Okay, so muscles uptake it, the insulin faster than fat cells, and then just utilizing it, eating habits. Okay, all those types of things that are there. And again, ignore the ketogenic diet because it's fat centric, but fiber is a big player. Fiber is something a lot of people don't eat a lot that are there. And I mean, very much I fell into that, let's say I wasn't fond of saying hi to the salad bar. Familial history, all those types of things are there. Gestational, during pregnancy, that can be normal. Okay, after your baby is born, it usually goes away. Yeah, unfortunately, that's the thing. So you fall into that category of pre-diet, and there's a lot of things that do that. Having enough of the risk factors, family members with diabetes, that reactive hypoglycemia, because it means it's all about sugar utilization. So a lot of the things that are there, the hormones typically play the role. So depending on the age, today it's much more common for women to start having children later in life. Much more. I mean, oh gosh. My sisters, she didn't get married, she was 23. Oh my God. 22 and a half. What's going on? Yeah. So again, all these different familial things, right before pregnancy. I don't know about the racial stuff. I don't want to get into it. Oh, here, this is now they're calling MODI. This was the metabolic syndrome or syndrome X. Okay. And runs strongly in families, mutational. They generally go on to develop before they're 25, and there's a lot of problems with that. Neonatal, uh, under 9 months, a different type than type 1, not autoimmune per se. Again, I don't know enough about it. What has helped? For years, all we had were diabetics originally, all they could do was do what we call test or use test strips. Same thing you would usually put into a pool to test for chlorine levels. You dipstick your urine. And if it was spilling over into the urine, then you knew there was a problem. And they had what was called a sliding scale of insulin. So if it was +1, you take a couple of units, +2, a couple more units, etc. That's a lot of times how they started and played around with it. And that was the default when things weren't working. You go back to that. We didn't have glucometers. But once you have glucometers, now you could spot test. But anything, it's a snapshot. A blood test is nothing more than a snapshot. So we have to be able to look at things. So is it valuable? Yes. For years, the way that you made the diagnosis of diabetes was basically a curve. The curve was time, starting at time 0 up to maybe as much as 7 hours. That measured your blood glucose. It's called glucose utilization curve or glucose tolerance test. You measure the person would fast overnight. Let's say you measure their fasting level of glucose. Let's say it was normal. Then between time 0 and about every half an hour, you do a blood test. Whether it was a finger stick or whether it was an actual venipuncture blood test, depending on what we had available to us. So every half an hour, 1.5, all the way out to maybe 7. And what we would do in this unit, they would ingest, and still done to get really handled. They'd ingest roughly 100 grams of carbohydrate. You had to drink like a cola that was sickeningly sweet and get it down in like 20 minutes. Fasting. So what's good? So how long you do with the test load? And what they were looking for, roughly a half an hour to 1 hour, it would certainly spike, then it would plateau, and typically you theoretically should be in the normal range, let's say that's 60 to 100, without getting the actual numbers, by about 2 hours. So that was called, if you had this, now understand, living systems don't make sharp turns. We do things, spike way up, they go way down. When you start to see reactive hypoglycemia, you have that kind of, we have to live with it. So that indicates that, and what's happening is insulin is being released, but glucagon is being released as well. As that sugar starts to go up, insulin is released. But immediately your body starts to release a little bit of glucagon to make that a little less of a sudden sharp turn. Would be the way to describe it. And this would be, if this was normal, then your 2 hour glucose tolerance test was good. This would be diagnosed. If we weren't sure, longer. So the screening test was called a 2 hour PP, which means a postprandial. So you tell somebody fast overnight, you tell them what they should be eating for breakfast, and come in 2 hours later. And then effectively you were trying to mimic this. As long as they fell somewhere in the normal range. Now other things have started to change. And so we understand that when you have a lot of sugar flowing around, now we have the magic. So now we can do fasting blood sugars, random blood sugars, glucometer tests, and good old hemoglobin A1. You know what the normal is? And that's glycosylated hemoglobin. How much sugar is stuck on your hemoglobin? You've got to get a handle on it because the way to treat diabetes is aggressive. You want to avoid the long-term complications, the neuropathy, the blood vessel problems, the strokes, the heart attacks, any of those types of things, the kidney failure. 75% of people will go blind, diabetes. 75% of people on dialysis or kidney transplants, diabetes. Diabetes, diabetes, diabetes. So glycosylated. So as you can see, if it goes over a certain amount, where it was, my last one was like way below that, like in the fours. And that was when I was eating everything under the sun up until about a month ago. You know, the Badger's fault. He got peppermint patties. I'm only human. And little Twix bars and Kit Kats. I'd kill for a Kit Kat. What am I doing? What's happening here? I probably lost it. We're running out of time anyway. And so I will go. What happened to my machine? I have to escape. One of those things where you don't know what the hell's going on. So, randoms, fasting, oral. That was also about the glucose tolerance test, follow-up testing, etc. And this is fairly straightforward, whether it's insulin and what it does and how it works. I'm not going to bore you with this. Uh, there are a lot of most of these have had significant problems. I was only familiar with the early generations. When we're starting to get down to these newer ones, I do not know anything about, nor what I know the earlier ones did not work particularly well. So again, these newer fashion, I don't know when this was made and whether this is that Ozempic type stuff. And I'd have to, frankly, I'll look it up and see if I can give you all some context. But I wanted to sort of summarize it all by saying that when you would see irregularities that weren't diagnostic of diabetes, suggestive, and then, like I said, if you saw irregularities, that's when you start to see pre-diabetes, particularly with family history. A lot of folks were like that. And I learned a lot about it. It was early, when someone is, it's a family effort because diabetics are the worst cheaters in the world. I can tell you how house calls I made with people with diabetes, and you look, you kind of get a snapshot inside the old nightstand drawer, candy bars. This is a lady who had one leg amputated. Well, I mean, I don't have any willpower. My biggest willpower now is not free worked out. It's not to get another candy. So, and what the Joslin Institute did, coming out of Boston, out of Deaconess, Woman Deaconess, Harvard Medical School, and all the Mass General, they basically said we need to get everybody, not just the person, not just children, parents, everybody there, wherever they were, make sure they exercise, make sure they eat properly. Call them out when they're cheating. And that really has kept a lot of those, the kidney failure, the losing limbs, all of that stuff down. It's like my favorite topic to talk about. All right, so Monday we're going to start blood. Monday, I introduced it a little bit from a lab perspective. I'm going to do it a little bit in lecture because we're going to do the blood testing thing in lab. If you're interested in it, I know not everybody can be here or will participate. That's fine. If you want to, I got new stuff. We have to be very careful. Dr. Badger, he circulated the university document. Like he's afraid, I'm sure he's afraid that you're all going to share needles. Not him, the university is. Because they understand universities have policies because of liability. So we're going to be very careful with blood. I got to run over.